Hello, everyone. My name is Jasmin Hundal, and I am a recent graduate from the Emory Fellowship at the Cleveland Clinic and incoming faculty at Emory University in breast medical oncology and survivorship. Today, we will be reviewing my recent published review article in JCO Oncology Practice, Glucagon-Like peptide 1 receptor agonists in breast cancer, metabolic, clinical, and survivorship implications. So when most people think about GLP-1 receptor agonists, they think about weight loss or diabetes. In oncology, however, we're beginning to ask a very different question. What role does metabolic health play in cancer care? That question was really the motivation behind our review. For many years, obesity has documented as a patient characteristic or comorbidity. Increasingly, we are recognizing that metabolic dysfunction is biologically relevant. It influences inflammation, insulin signaling, hormone production, and the tumor microenvironment. It can also affect the treatment tolerance, quality of life, and survivorship. As a result, metabolism is an important part of our conversation in breast cancer care. Why is this topic important now? The timing couldn't be more relevant. GLP-1 receptor agonists are now being prescribed at a higher rate. As oncologists, we're seeing more patients who are already taking these medications or who are asking whether they should. The challenge is that clinical adoption has outpaced the evidence. We have excellent data supporting that these drugs are great for obesity, diabetes, and cardiovascular disease, but we have far fewer prospective data in patients with breast cancer. That leaves clinicians with many practical questions, such as, can these medications be used safely during treatment? Do they interact with endocrine therapy or chemotherapy? What should we monitor? Which patients are most likely to benefit? And perhaps most importantly, do these improvements in metabolic health translate into better cancer care outcomes? Those are the questions we wanted to synthesize in this review. What does the current evidence tell us? One of the biggest evidence or messages that we should separate what we know from what we hope. The current evidence suggests that GLP-1 agonists can achieve clinically meaningful weight loss in patients with breast cancer, although the magnitude appears somewhat less than what has been observed in obesity clinical trials. Again, this is all based on retrospective data. We also know that these medications improve glycemic control and reduce cardiovascular risk. At the same time, we don't have evidence yet that they reduce breast cancer recurrence or improve survival. Most of the available data remains retrospective. So while the findings are encouraging, they should not be interpreted as proof of anti-cancer effect. One of the most interesting aspects of this field is that it extends well beyond the number on the scale. We discussed potential implications for body composition, sarcopenia, breast imaging, lymphedema, cardio-oncology, and survivorship. For example, rapid weight loss can affect lean muscle mass, making resistant exercise and adequate protein very important considerations, and they should be prescribed concurrently. We're also beginning to see emerging data suggesting potential cardiovascular and lymphedema effect, although these observations still require prospective validation. There are types of practical issues clinicians will increasingly encounter as more patients receive these therapies. What should clinicians be thinking about today? I don't think the message is that every patient with breast cancer should be receiving one of these agents. Rather, I think the message is that metabolic health deserves a greater attention within oncology. We should think about weight, insulin resistance, cardiovascular risk, physical function, and body composition as part of comprehensive cancer care, not separate from it. The goal isn't completely just based on simple weight loss. It improves the overall health of our patients while maintaining effective cancer treatment. What excites you most about this field? What excites me most is the emergence of what I think is metabolic oncology. We're moving beyond viewing metabolism as simply a patient characteristic. Instead, we are beginning to understand it's an important component of cancer biology, treatment toxicity, and survivorship. This creates opportunities not only for new research, but also for new models of multidisciplinary care involving oncology, endocrinology, cardio-oncology, rehabilitation, nutrition, exercise medicine, and lifestyle medicine. What research is still needed? The next step is prospective clinical research. We need studies that define which patients benefit most, when these therapies should be started, how they influence treatment delivery, and better improvement in metabolic health ultimately will affect recurrence, survival, and quality of life. We also need implementation research, because even if these strategies prove beneficial, issues such as cost, access disparities, and long-term adherence will determine whether patients can actually benefit from them. I hope this review helps clinicians navigate questions they're already facing in practice, while also encouraging a broader conversation. As oncology continues to advance, our focus shouldn't be only on developing better cancer therapies, it should also be on optimizing the health of the patient receiving these therapies. Metabolic health is becoming an increasingly important part of the conversation, and I think we're only beginning to understand its role in breast cancer care. Thank you so much for your time, and please let me know if you have any questions or concerns. Thank you.